about 1,900 patients in the last 10 years, among them 187 children, which represents about 10% of our patients. The most common pathology was AVM with 52%, followed by tumors, 42%, and 5% was functional disorder. The largest series of stereotactic radiosurgery in pediatric population is in Russia, just communicated a few weeks before by Andrei Golanov. He treated over 190 pediatric cases, through them 1,500 tumors. The third of those cases were treated by gamma knife. The tumors treated at our unit are glioma, craniopharyngioma, pineal tumors, medulloblastoma, and the NF2 tumors. Concerning gliomas, even if we all know that gliomas are non-focal lesions, stereotactic radiosurgery will be helpful for deeper focal gliomas or focal remnants after subtotal removal. But must be conceived only in a multimodal strategy. Among all gliomas treated, 31% were children, with half of them being in the cortex. At the last clinical and radiological follow-up, 30% had a decrease of the tumor volume and 35% were stable. 2 cystic recurrence were operated and 1 death due to a brainstem glioma. There is unfortunately a need to improve the technique for glioma to assess better results. In fact, new techniques are developed which bring us new perspectives, like the PET-guided radiosurgery or the MRS-guided radiosurgery that uses SPECT to determine the tumor margin. It can also be proceeded in some application to determine the hotspot and give the maximum 50% isodose on it to be the most efficient. Dr. Fred Derkawi is working on it for his PhD. Here is an example of a grade 2 Rolandic astrocytoma operated. The follow-up of the radiated remnant shows a decrease of its volume and a better visualization of the cortex after 1 and 2 years of the adjuvant treatment. Optic pathways gliomas and the big problem of oncology can also be treated by fractionated stereotactic radiosurgery, like this 10-year-old girl with a chiasmus glioma before and after 2 years of follow-up. You can see the beautiful results on the imaging. The patient had a stabilization of her visual acuity. We have to keep in mind in this kind of lesions that the fractionament in sometimes is mandatory to preserve the visual function or what remains of it. This is the benefit from ICON. This is a recurrence of an operated ependymoma in a 6-year-old patient that we treated successfully with ICON, and we can see her results at just 1.5 years. But as everyone knows, all that glitters is not gold. The perfect example is this thalamic astrocytoma in a 16-year-old patient. He was treated with a cyst puncture and stereotactic radiosurgery on the solid portion for this lesion. Is unfortunately at the follow-up, the patient showed severe symptoms of intracranial hypertension despite of severe puncture via Ommaya reservoir. I then operate him, and you see the results after surgery. He is now studying medicine in Senegal. That is why it's mandatory to choose the indication of radiosurgery. The target has to be identifiable by imaging techniques, and the volume target has to be acceptable. It could be indicated in lesions that aren't accessible through the scalpel. It should be used as a part of a protocol to assess a good tumor control. So again, the case selection is really important. To summarize, it is an effective tool for many patients. It should be performed as early as possible. One must differentiate reactively degenerative changes and the tumor progression on follow-up. There is a bridging case of lamina tecti glioma. Here is a case, she was 17 years old, treated for this glioma, and you can see beautifully how the tumor disappeared on the last control at 9 years. So what's about pineal region tumors? For this kind of tumors, the treatment by gamma knife remains a pillar in the management. 7% of our patients were pineal region tumors, which represent 11 patients. Here is the case of a 14-year-old female with a pineocytoma. After 3 years and 5 years, we can notice an obvious reduction of the tumor volume. Again, we need to be careful on indications. Here is another case of a germinoma in a 16-year-old patient treated at the first with no histology proven for a pineal region tumor. The 1-year follow-up showed tumor expansion. With a cystic formation, the patient then benefits from a cyst puncture and biopsy of his lesion, revealing a germinoma as expected. He underwent a series of chemotherapy with a good control at the follow-up. In fact, pineal region tumors has a wide histological variance. Some authors have discussed the necessity to perform stereotactic biopsy before the gamma knife because the response of these tumors are better with chemotherapy, like in cases of germinomas. These two very large series from Wento and from John Regis showed that benign tumors, the response of benign tumors are better than the malignant one in this region. So what about craniopharyngioma? The department has a big experience of microsurgery of craniopharyngioma from 1983 to now. We operated at about 350 cases. So we have treated some cases with a combined option, and we treated 42 cases in the department of gamma knife, among them 25 pediatric patients. Sometimes it is necessary to perform a stereotactic puncture of the cyst during the procedure to reduce the volume of the lesion for better outcome. With a mean targeted volume of 13 cc's and a mean duration of the procedure of 75 minutes. The dose go from 8 to 14 days. So craniopharyngioma are well known that with their radio resistance in radiotherapy, but they are very sensitive with the gamma knife. So with a mean follow-up of 42 months, 25% had no modification on their neurological status, 10% showed deterioration, and 65, two-thirds, improvement. Of course, all of our patients are followed by visual, endocrine, and MRI tests. It has been demonstrated that the volume decreased from 12 to 7 cc after gamma knife. So in the literature, there is an improvement of the progression-free survival and the overall survival on Kaplan-Meier test. Quality curves. Quality of life is higher after the combined treatment than after primary total removal. Here is a little reminder about the side effect on total removal of craniopharyngioma. Case of 7-year-old patient with a cellular and supracellular lesion with endocrine troubles, with a disappearance of the lesion at 6 years follow-up. This case illustrates a giant cellular and supracellular craniopharyngioma, mostly cystic, with a posterior expansion of the cyst compressing the brainstem. The management supposed an evacuation of the cyst for tumor reduction and then a post-evacuation MRI was performed, then the patient was treated by gamma knife. In summary, gamma knife and fractionated one are very effective treatment methods for craniopharyngioma management. It is a safe strategy for endocrine, visual, and diencephalic functions than total removal of the lesion. A combined treatment provides a higher quality of life with a higher progression-free survival, which makes it the method of choice. One of the nightmares of neurosurgeons are neurofibromatosis. So they represent 1 to 3% of pediatric tumors. They tend to occur school-based. Surgical approaches is the standard followed by radiation in malignant or not accessible for radical resection. External beams cause high dose to temporal lobe, impacting memory and development of the child. Can also cause moya-moya disease by the obstruction of the small vessels of the school base, and limited reports on pediatric population in the literature. We published with my dearest friend, Dr. Faisal Lakhdar, a paper about pediatric meningioma which was included in this meta-analysis on 677 children, demonstrating that children meningioma are nothing like adults. They are more aggressive, less aspirable, making their management harder, obliging in most cases the use of combined approach. This is an example of an occipital meningioma in a 15-year-old patient treated by stereotactic radiosurgery, and you can see the tumor control at 2 years follow-up. Another case is of a patient with multiple meningiomas and vestibular schwannomas treated by gamma knife on one session, which provides the efficiency of gamma knife in this kind of lesions. So concerning now malignant tumors, I'm going to speak just for one. The famous and the most frequent is medulloblastoma. The only indication of gamma knife is the recurrence after failure of recommended options. For a patient with medulloblastomas, the treatment is indicated in cases where there is no spinal metastasis, depending on the tumor volume. The combined strategy of surgery, radiosurgery, and chemotherapy are very efficient. As an example, this case of a 4-year-old patient with this intraventricular lesion that respond to gamma knife, and the control is very well 8 years after. So the other part of my talk today is vascular lesions, and you know that they represent a major proportion of a patient treated in most of a gamma knife series, but their management is still controversial and complex. Both microsurgery and endovascular techniques have shown their limits in large and risky located AVMs. Radiosurgery, on the other hand, has proven its benefits, leading to progressive obliteration of the AVMs after 1 or 2, 3, 4, or 4 years. So the first gamma knife for AVM was performed by late Ladislau Steiner in Stockholm in 1970. It's a technique indicated for deep located AVM, AVM in critical locations, residual AVMs after prior treatment, and large volume symptomatic AVM with no other options. So how does gamma knife impact the AVM? One several aspects, inflammatory chronic process that leads to an endothelial proliferation, fibroblastic activity that causes hyaline deposit. They explain the delay of response 2 or 3 years. Unfortunately, there is no obvious size limit, but no topographic limits too. This curve shows the dose response of the AVM nidus according to the minimum dose within the target volume, with a wonderful response starting at 20 gray. According to the volume of the nidus, we assess better response at a volume lower than 5 cc's, with an 80 to 90% of obliteration, whereas for a volume over than 10 cc, only 20% of obliteration is assessed. We treated in our department 96 pediatric cases of AVM with more than 2 years follow-up, and the indication depends on a volume and location. The mean volume was 3 cc with more than 50% being less than 5 cc's, and the mean margin dose was 22 gray at the 50 ISO dose line. Here is an example of a 12 years old who presented with a headache and epilepsy. Imaging showed a large frontocallosal AVM. She underwent embolization prior to radiosurgery, and as you can see at the 4-year follow-up, the disappearance of the AVM. Another case of 16 years old with the right thalamic AVM with a volume of 2 cc's revealed by intracranial hemorrhage. On the left, you can see the planning in the gamma knife treatment, and on the right side, control after just 1 year of treatment, showing a more than 50% volume reduction, and the angiography control was normal at 3 years. So patient had MRI and angiography for their follow-up, and it shows 79 cases of obliteration with a response rates of 90% to 100 for volume ranging from 1 to 5 cc's. Results were controversial for large ones with 25 to 74%. 6 patients from our department were retreated second time. J'ai un problème. So how about the management of large ones? We all the challenge that they imply, but staged volume surgery can beautifully answer to that. There is the implant staged procedure to repeat treatments for smaller remnants, the planned staged procedure for the treatment of different volume, the repeated treatments to the same volume, also known as the hyperfraction. All that is made possible with the newest machine like ICON. There is a very interesting case of a 15-year-old patient with this large posterior fossa IVM with the large zones of angiogenesis and large drainage veins. The planning allowed us to treat a volume of a big one, 32 cc's, thank you Adil, at 17 gray. Because of the proximity of brainstem, the result of at 8 years was wonderful, like you see down, and small cerebral remnant was treated recently. In our series, there was no mortality, but 6% of our patients present epilepsy. Perilegional edema was developed on 15 cases, and in 6 cases, it led to a neurological deficit with 2 brain impairments. There was no cyst formation and no hemorrhagic stroke in our pediatric population. Here is an example of a post-radiosurgery edema at 1 year leading to neurological deficit. The patient was managed with steroids with a good recovery. So, cavernous malformations, we have a slight good experience in this kind of vascular malformations. Introduction of radiosurgery provide benefit for large number of patients with excuse me. There are situations in which cavernous malformation lie in regions of the brain that are not eligible for microsurgical resection with acceptable risk-benefit balance. Stereotactic radiosurgery has been reported to be a safe intervention that provides short-term reduction in risk of hemorrhage after an initial interval of latency in a patient believed to be harboring this particularly high-risk cavernous malformation. The results reported in a large series in the literature shows significant decrease on the hemorrhage rates. Some series reported a drastic drop after the 2 or 3 years. We have treated in our institution 23 patients, 12 were pediatric. Symptomatic hemorrhage appears to preponderate the clinical presentation, about 40%. The most represented locations are supratentorial, 43%, midbrain, 39%. 80% of our patients reported symptomatic improvement with the noted regression of neurological deficit and seizures. About 18% remained stable. So, there is a case of adult one treated by gamma knife, and the result was good 36 months after the treatment. In conclusion, for vascular disease, symptomatic cavernoma should be resected when possible. If not, radiosurgery is a treatment option, but requires strict eligibility criteria. It provides protective effects, symptomatic improvement, and minor complication. Most of AVMs treated in our department by radiosurgery have a good follow-up, and gamma knife is now one of the famous options of the treatment of AVM. Just we treated one case of venous Galian malformation in our department. I don't have the results yet, but some cases have been described in the literature of vein of Galian aneurysmal malformation with encouraging results, as showed by this case of 3-year-old patient treated by stereotactic radiosurgery with an obliteration at 2 years. What about the functional radiosurgery? Our gamma knife unit has a limited experience on functional radiosurgery, but we performed 10 cases, 7 hematoma, and 3 cases of epilepsy. The indication of radiosurgery on functional disorders are mesiotemporal epilepsy, hypothalamic hematomas, epilepsy lesions, and disconnective callosotomy. I could not talk about functional radiosurgery without giving homage to this great man, Professor Jean Regis, leader in the field of functional stereotactic neurosurgery, who I had the honor and privilege to work with. The launch of functional stereotactic radiosurgery was a teamwork with an experienced epilepsy surgery group and an experienced radiosurgery group chaired by my mentor, Professor Abdesalam Al-Khamlishi, and my friend Adil Melhawi. It is mandatory to select the patient for a good functional outcome. This is a beautiful series treated in Marseille by Adil and Professor Jean Regis on mesiotemporal epilepsy. They provide that 60% of the patients had a release of the seizures during follow-up. That there is no real need of MRI changes observation for clinical improvement of the patient, but there is a need of MRI to detect complications. The mass effect score status on the complications, with the major one being edema. This is a 9-year-old child who benefited from a callosotomy in my department for a Lennox-Gastaut syndrome with a good clinical and morphological result. Like you see here, the metabolic flow-up shows anterior callosal atrophy. So radiosurgery might be an alternative to microsurgery for highly selected cases, and can be safe and effective for functional disorders. Hypothalamic hamartoma, verbal memory sparing, and lesional epilepsy are a good indication. The target should be well chosen with the minimum volume possible. It presents a delayed clinical efficiency with sometimes no MRI change. The last part is psychological disorders. It is not a new indication. It has been studies in the 70s, many surgeries can be proposed like anterior callosotomy, cingulotomy, amygdalotomy. Many series have been published not far from here, just across in the Mediterranean Sea. Dr. Martinez, our friend, Martinez team in Madrid has treated more than 120 cases of OCD. There is the target. Look at the volume, which is more, just 2 4mm collimators, and look at the dose, which is higher, 120 grays. Many psychological tests have been studied in obsessive compulsive disorders with low improvement. No complications have been reported. In conclusion, gamma knife is a pillar in the management of children disorders, tumor, vascular lesions, functional disorders. This tool must be kept in mind in the therapeutic arsenal to preserve the cognitive and endocrine functions of the child that is experiencing cerebral growth. Thank you very much, and see you soon in Rabat with in Europe and Gamma Knife Society meeting. We are waiting for your abstract. Thank you very much.
Thank you, Professor Alha, for this very nice presentation. May I ask you for questions?
Thank you, Yassir, for this overview of the technique and the indication in the pediatric population. It's, as you said, this is very important because the child is growing up and his brain is very sensible to many injuries. And in the industry, there are any inferior limits of age that not contraindicate, that limit the technique. Is it before the age of the patient or the problem or just the frame?
The limit is broken now with the icon. Why? Why? Because the thickness the limit was the frame, but now there is no limit because we can use the mask, and we use the mask for a 3 years old patient with remnants of ependymoma without any problem. We have a good anesthesiologist, and the problem that they spend all the time from the beginning, from the 8 to 8, with the patient. And so with the mask now, we can treat safely patients under 3 years old for brain tumors or AVM disease. I hope So, Professor Hamji, don't
Just to congratulate you, Yassir, with Adil, who are doing very, very good job with all the colleagues, neurologist and intensivist. I think that the introduction of this technique of radiosurgery in Rabat since now 11 years in 2008 has brought really a lot of improvement in our practice, and also it has another advantage. It pushes the neurosurgeons to be more,
prudent.
Yes, in microsurgery, because as you have seen, the best results are found in the smaller lesions. In our places, we are seeing a lot of large lesions, so you need a good and well-trained microsurgeon to reduce your lesion if they cannot remove it at all. And also, I think the last and big progress is the hypofractionation and the staged radiosurgery, which is allowed now, very, very nice, with the new machine who are already there and who we get in 2017. So it's an occasion just to congratulate all of you, and of course the companies who are supporting this technique. Thank you.
So thank you.
Tu peux venir?
Oui. So thank you very much for assisting to the Electa Symposium. Waiting for you on our booth if you need other information or answering questions. Professor Baratas will be present with us, and as well as Mr. Anup, that everybody knows, to ask about, to answer your question about Versa HD doing radiosurgery on brain and on spine, and Anup explaining again how ICON have been improving the treatment without using the frame for cases like the pediatric cases, which is the theme of this Congress. Thank you very much.